Hi, this is Dr. Perry Carpenter. I'd like to thank you for joining me on today's program. Today's program is from the Special Population Series, and today's program is entitled Exercise Prescriptions for Orthopedic Injury and Rehabilitation Clients, or in our case, we could refer to those as chiropractic patients. I have a fascinating program for you today, and it's a program that I'm sure will provide invaluable information for you as you handle your chiropractic patients that have specific conditions that require your help in the rehabilitation of those conditions. And let me just take a moment to introduce myself to you. This is Dr. Perry Carpenter. I'm a chiropractor. Been a chiropractor for approximately 28 years now. I graduated from Palmer West College of Chiropractic. And throughout the years, I've taken many different types of continuing education courses. And I list for you here some of the courses that I've completed that qualify me to speak on today's topic. And specifically, I'm going to be making extra reference today to materials derived from the National Strength and Conditioning Association, of which I'm a member. I hold two credentials with the NSCA. I hold the Certified Strength and Conditioning Specialist credential and also the Certified Special Population Specialist credential. And today's material is largely based on ideas, references, and concepts about rehabilitating and treating persons who qualify as special populations. And today we're talking about that group of special populations that we find in the chiropractic practice, and that is people who have healthcare issues. Specifically, today we're talking about injuries and issues with the musculoskeletal condition. So today's program is about injury, orthopedic, and rehabilitation patients. And those certainly qualify as special populations. And those are certainly people that have special and unique needs perfectly suited to the work that we do as chiropractors. So I'm going to be supplementing chiropractic material today with additional material derived from the exercise sciences. And I will be quoting some references from the National Strength and Conditioning Association. References for today's program are many, and draw your attention to a couple of textbooks from the National Strength and Conditioning Association. I'll be presenting information from the Essentials of Personal Training and also the Essentials of Strength Training and Conditioning. I'll also draw upon material out of Lippincott's Primary Care Orthopedics 2nd edition. I'll refer to Yoakum and Rowe Essentials of Skeletal Radiology, specifically when we get into a discussion later on the rehabilitation of spondylolisthesis and spondylolysis. I'll be drawing on some physical examination procedures from the Fundamentals of Musculoskeletal Assessment Techniques. That's a fabulous textbook by Palmer and Epler, a couple of physical therapists. I'll make also a brief reference to the AMA Guide's 5th edition, and those of you that are qualified medical evaluators, you'll recognize those references. And then I have a couple of specific references for you relating to the shoulder and the lumbar spine. And I chose and selected these references for a couple of different reasons. Number one is they relate exactly to topics that we're going to be discussing, specifically related to the lumbar spine and specifically related to the shoulder. And also because each of these articles illustrates some general principles that are extremely important principles that we understand regarding injuries and rehabilitation in general. And I'm going to make early references to each of these principles early in the program. And then when it comes time, when we get to the lumbar spine section and when we get to the shoulder section, I will reiterate these principles by drawing upon these references, specifically as relates to the region that we're considering, whether it be the shoulder or the lumbar spine. And I know you're going to find these references to be fascinating, and these are some principles that are illustrated in these references that you can rely on and that you will rely on in your practice from now to forever. Okay, so let's move on now and let's talk about rotator cuff conditions, including rotator cuff injury, rotator cuff tears, and even rehabilitation of those cases that have required a surgical repair of the rotator cuff. Now, rotator cuff is almost a ubiquitous condition nowadays, especially in the active populations that are involved in sports activities, especially the overhead activities such as volleyball, tennis, and also in the recreational weight training population that involves heavy loading on the shoulder, which is otherwise a non-weight bearing joint, but with weight training activities, we convert the shoulder from a non-weight bearing joint to a weight bearing joint, and this can be injurious to the sensitive and delicate rotator cuff. So rotator cuff cases are almost ubiquitous in chiropractic offices, so it becomes important to know how to properly treat and properly rehabilitate these cases. Now, rotator cuff injuries can be seen in all age groups, across all spectrums, and across all populations. Now, in young people, it's usually the result of a traumatic injury, or in those with unusual demand on their shoulders, such as baseball pitchers and and swimmers. And I frequently see rotator cuff injuries in those young athletes who are involved in sports that involve falling or that involve collisions. Many times, for example, if you consider a hockey player, when a hockey player is getting close to the boards and he's about to be hip checked into the boards, he may put his arm out to soften the blow between him and the boards. And as his body is driven against the boards and as his arm is forcibly forced into a vigorous eccentric contraction to decelerate his body towards the boards, this can cause overload and stress to the rotator cuff, and in some instances can cause tearing and even rupture of the rotator cuff. So in young persons, it's usually a traumatic situation. With older patients, the musculotendinous structures lose their elasticity, and then over time they can become vulnerable and can become injured even with common everyday activities and stuff that you might not ever consider would cause an injury to the rotator cuff. And these are the type of injuries that can occur right out of the blue with absolutely no warning. Now, the most common symptom of rotator cuff injury is, of course, pain. And the pain is located outside the shoulder. It's located in the upper arm, and it can be located as far down as the deltoid region. Other symptoms associated with rotator cuff injury include a feeling of generalized aching, which can become a specific sharp pain with certain activities that provoke the injured tissue. Can include loss of range of motion of the shoulder, particularly at the extremes of the range of motion, or with particular isolated ranges of motion such as external rotation. Can also include feelings of catching, feelings of crepitus, feelings of stiffness, feelings of like a gristle or soft tissue grating sound, or a skipping, clipping, clicking, clunking type of sensation as the arm goes through various ranges of motion. Now, one of the key physical examination findings that we encounter with rotator cuff injury, including rotator cuff strain, rotator cuff partial thickness tear, even rotator cuff full thickness tear, involves what's known as the painful arc. And the painful arc involves pain on abduction between 60 and 120 degrees of abduction. So here shows our patient abducting the arm between the ranges of 60 and 100 degrees of abduction. This would be 90 degrees of abduction. And the reason this is a painful arc is because it's in this position between 60 and 100 degrees of abduction that the rotator cuff function is important. Part of the function of the rotator cuff is to depress the head of the humerus within the glenoid cavity. And in the absence of proper function of the rotator cuff, the head of the humerus tends to ride high in the glenoid cavity as it's driven superiorward by the forceful contraction of large muscles such as the deltoid muscle, such as the pectoralis major muscle, and such as the biceps brachii muscle. All of those muscles have their muscle fibers running longitudinally along the axis of the humerus bone. And when those muscles contract and shorten, they effectively pull the head of the humerus tight up into the glenoid fossa and against the acromial arch. Well, it's the purpose of the rotator cuff to depress the head of the humerus so that the head of the humerus can remain free to articulate around unencumbered between the glenoid cavity and the subacromial space. So with failure of the rotator cuff, we get a high riding head of humerus, which compresses the subacromial bursa, the supraspinatus tendon, and the long head of the biceps tendon against the subacromial arch. And this is manifest on physical exam as a painful arc. We'll also see weakness to resisted manual muscle testing of specific muscle groups. And you should be familiar with the specific physical examination maneuvers for the supraspinatus, for the infraspinatus, for the teres minor, and also for the subscapularis. Now with rotator cuff rupture, we're going to have a failure of the initiation of shoulder abduction. And sometimes examinees can trick us in that they can still accomplish some shoulder abduction, but they do it by substituting scapulothoracic motion for actual shoulder abduction motion. So the rotator cuff, and specifically the supraspinatus muscle, is responsible for initiating shoulder abduction. It's not the primary shoulder abductor. We have the larger deltoid muscle for that, but the supraspinatus muscle helps to initiate abduction. And so with a rotator cuff injury, we may see substitution of scapulothoracic motion for shoulder abduction. So you need to be on the lookout for that. We may also see the external rotation lag sign. And to perform the external rotation lag sign, we place the patient's arm at the side and we flex the elbow to 90 degrees. We then rotate the humerus to maximum external rotation. Now, if the infraspinatus and the teres minor, the external rotators, are torn or weak, the arm will then drift back to internal rotation due to the unopposed action of the internal rotator subscapularis. So there's a couple of physical examination maneuvers that will pretty much identify the majority of the rotator cuff injuries that we will encounter. Much less common to encounter is an injury to the subscapularis. Our primary rotator cuff injuries are going to be to the supraspinatus, the infraspinatus, and then to a lesser degree the teres minor, and then to a much lesser degree the subscapularis. So let's talk about some general movement and exercise guidelines for the rehabilitation of rotator cuff injuries. Um, Generally, with rotator cuff surgeries, the post-rehabilitation period is extensive because it begins with a period of prolonged immobilization of the shoulder. But as the patient initiates formal rehabilitation, exercises generally begin with isolation, single joint, single muscle group type of exercises. And we've talked about some of those exercises earlier with regards to shoulder impingement and shoulder instability. Now, after the patient is discharged from formal rehabilitation, that's when we get them in the chiropractic office. And we want to make sure that we're on the same plane as a starting point with their prior rehabilitation therapy. So in general, we transition from isolation exercises to multi-joint exercises when the examinee demonstrates full range of motion and full pain-free function in the isolation exercises. Only then do we progress to compound multi-articular and multi-joint exercises that involve the rotator cuff not only in movement of the head of the humerus, but in stabilization of the head of the humerus throughout various compound movements. Any movement that causes pain is contraindicated. Typically, repetitive overhead types of movements are going to be the most painful to the patient. And you need to be aware and sensitive to the presence of pain in the patient. And you need to always inquire to the patient as to the presence or absence of pain. Now, because there are 100 different exercise sequences that we can employ for rotator cuff rehabilitation, it's important to eliminate any exercise or any movement that even remotely is noxious to the patient. And this is sometimes something that you need to explain to the patient. You need to explain that to the patient that there's two kinds of pain. There's good pain and there's bad pain. And many times patients, they don't know the difference between good pain and bad pain. And sometimes this is confounded by monikers in the media such as no pain, no gain. Well, you need to explain to the patient that pain, bad pain, is pain that's noxious. Noxious describes injurious pain, damaging pain, bad pain, pain associated with tissue damage and tissue injury. That's noxious pain. Noxious pain will generally be accompanied by some sort of weakness, such as a painful arc, such as a point of give way, such as a point where strength is diminished compared to other positions within the range of motion. So you need to explain this to your patients. We don't want any noxious pain. Do not cause the examinee noxious pain, because that will only set their condition back. When you encounter painful movements and painful exercises, those are something that we can come back to at a later time when the examinee has progressed through sub-stages of rehabilitation in order to work their way up to the painful exercise. So anything that's painful has to be discarded. Typically, the painful activities are going to involve overhead activities, and those activities that involve wide angles of abduction of the glenohumeral joint, such as push-ups, such as chest presses. Now, it may be that your particular examinee, for some reason, has no pain with overhead exercises and has no pain with push-ups or chest presses. In those situations, the examinee can then do those activities and can do those motions. But again, there still needs to be a supervised, plan of progression of those exercises. And the progressions proceed through progression in range of motion and also progressions in loading schemes. So we demonstrated this before. This is an example of a shoulder external rotation exercise to strengthen the infraspinatus and the tear. Okay, this is another exercise known as the empty can exercise, and I want to contrast this exercise with what we see in the modern health club known as the side lateral raise. Now, the empty can exercise is an exercise that's used for the rehabilitation of the supraspinatus muscle, and it's an excellent exercise for that if it's done properly. Now, notice here that our patient has his arm in internal rotation with 60 degrees, or he's demonstrating slightly more than 60 degrees of shoulder abduction / shoulder flexion. And he's raising his arm in what we refer to as the scapular plane. You'll notice that his hand finishes in front of the coronal plane of the body approximately 30 degrees. And this is called, the movement is called scaption. Movement in the scapular plane is called scaption. Now, scaption provides the greatest degree of freedom of movement of the glenohumeral joint. Now, because the arm is positioned in internal rotation, the greater tubercle of the humerus bone potentially will abut the acromial arch of the scapula, approaching 75 and 90 degrees of shoulder elevation, whether that be abduction or shoulder flexion. So the way you see people doing this exercise in the gym is only going to contribute to shoulder impingement syndrome and rotator cuff strain because of the internal rotation position. Now, in the gym, I prefer to recommend that weight trainers do the full can exercise. This one here is described as the empty can because you can see this position would simulate the emptying of a can of Coke. Well, if he was to turn his hand counterclockwise into external rotation, the greater tubercle would clear the acromial arch and would allow for unimpeded elevation and unimpeded abduction of the shoulder and be a very useful exercise for strengthening the deltoids and the entire shoulder complex. But for rotator cuff rehabilitation, we want to stick with the empty can exercise, no higher than 60 degrees of shoulder abduction / flexion. And she's right here demonstrating approximately 45 to 50 to maybe as many as 60 degrees shoulder elevation. This would be 90 degrees of shoulder elevation. Now, it's important that the maneuver be carried out in what's called the scapular plane. So this view here demonstrates that the patient concludes or completes the movement with the hand positioned in front of the coronal plane of the body here. This is in the plane that the scapula sits on the thorax. This is known as the scapular plane, and this movement is known as scaption. So this is an excellent rehabilitation exercise for the supraspinatus muscle. Progressing based upon the patient's tolerance, we progress from isolated and uniarticular exercises to compound multi-articular large muscle group exercises. So this shows here on the left, it shows the patient going through the compound exercise of the shoulder press. This is an overhead movement, and it becomes a rehabilitation movement by adjusting both the range of motion that the shoulder goes through and also by accordingly adjusting the load applied to the shoulder. So this allows the shoulder to function in its the rotator cuff to function in its stabilizing role as the glenohumeral joint goes through range of motion. As the patient continues to progress, we move from stable loads that are stabilized by means of machine apparatuses, to unstable loads that require additional stabilizing input from the patient themselves. So the progression in this sequence would go from left to right, always adjusting and modifying for range of motion, and always adjusting and modifying for load. Here we see two patients using dumbbells to exercise their shoulders and their rotator cuff. One is on a stable platform but using an unstable load. The unstable load consists of the dumbbells. The female on the right is doing the same unstable load, as she's also on an unstable surface. So this requires tremendous activation of scapular stabilizers, shoulder stabilizers, and simply to hold these weights overhead in this position. If you try this maneuver on an unstable surface and you just wiggle around down here, you realize how much stabilization is required to maintain stationary those weights. And all that stabilization comes from the deep glenohumeral stabilizers and scapula stabilizers. And so this is a fabulous exercise, and many patients report that after they do this exercise, their shoulder feels so much better. So it's almost like a pain relieving type of exercise. Okay, so
rolling. This part we're going to be editing out, so I'm just getting set up. Time to set. Which shoulder is involved? Left one? Time and set.
75-year-old patient. We'll call him Bruce. And Bruce had a pair of left rotator cuff, and he's now in the post-rehabilitation program with me. And we're doing several modifications to exercises that he can do safely, that he can do comfortably, that will help restore strength, restore range of motion, and restore function to his shoulder over the course of time. So I'm going to start this movie, and I'll narrate as the movie progresses. We're going to begin first by assessing Bruce's range of motion, so that we can see the range of motion depth of the shoulder. So we'll go through range of motion.
It's coming out.
Aptly scratch maneuver. Motion in adduction, flexion, and internal rotation. Looks pretty good. Abduction, external rotation is limited to about 90 degrees, and you see him substituting motion. And the external rotation is greatly limited, and you can see that it's a bit painful. Here's internal rotation, adduction, and shoulder extension simultaneous, and he's able to do it, but you can see that there's some loss of range of motion and there's pain. Shoulder flexion is probably quite limited, and you can see that it's a struggle for him. He substitutes thoracic and lumbar extension. Here's shoulder abduction. Comparing it with the other side, he does not like that maneuver. Okay, so you can see that there's quite a bit of adhesion and limitation to left shoulder range of motion. Well, so what can we do with this guy? Well, we can give him some activities that are adjusted for range of motion or adjusted for load. Now, we'll notice here that he has some load on the barbell. This is a weight that he's been able to work up to over a period of many months. And this is a comfortable range of motion for him. that he can continue to develop strength and continue to retain function in the shoulder in a manner that's safe and does not threaten the rotator cuff repair. So you'll see that he's doing partial ranges of motion in the strongest part of the range of motion and in the pain-free portion of the range of motion. He's exercising his chest, his deltoids, his triceps. He's getting quite a workout by modifying the range of motion.
And rolling.
Here's another
Go ahead.
exercise that modifies the range of motion. This is now a closed kinetic chain exercise. The one that we saw was an open kinetic chain exercise. So this requires tremendous stabilization of the scapular muscles, shoulder stabilizer muscles, minor, such as subscapularis, major, short side, well, this.
And rolling. Go ahead.
And because of the position of the bar, the load compared to body weight is greatly minimized. But he's able to pump out some repetitions with fair amount of shoulder abduction, you'll notice. Look at the shoulder abduction position, and he's able to do it in a way that's pain-free and that it's a sufficient load that he's able to continue to develop muscle and prevent atrophy of his upper body. And he can pump out a lot of reps here with no pain. And you can see that he's gotten quite a workout effect from that. Okay, I have one more exercise to show you. This is using the table apparatus, and it provides a different portion of range of motion here. And we introduce some instability into the system by moving from a fixed stationary apparatus of a bar to the unstable condition of free handle as the hand moves in an open kinetic chain exercise. So this introduces quite of instability into the system, all of which has to be stabilized through use of the rotator cuff. So notice how he modifies his position and his range of motion to a pain-free range of motion. And you'll notice he's able to use a fair amount of weight here. He's able to use quite a few weight stacks in order to get a hypertrophy stimulus of his pectoral muscles, deltoid muscles, tricep muscles, and he's able to get an adequate workout stimulus in a way that does not aggravate his rotator cuff repair. So he's doing a fabulous job with the instructions that we've provided him, and he's able to exercise in a manner that's safe and that he's confident that he can successfully and safely complete. Okay, so that concludes our section on the shoulder now, and we're going to now transition into our next section.